In this lecture, we're going to be going through the human viruses, and clinically speaking, we're going to talk about how they're transmitted, what their diseases that they cause are, and in many cases, how you detect them. Of course, you can do in general, which is in most cases with a viral culture, the doctor doesn't really know exactly what the virus is. So a viral culture is frequently ordered in cases where you're kind of just you've ruled out bacteria and you're not sure what's causing this disease. So you're kind of sort of, it's like a bird shot, just trying to catch everything. Whereas nucleic acid testing, you actually have to test organism by organism. So in the case of a viral culture, and this is just a chart of some of the common ones that we get requests for. We get requests for things like the most common causes: adenovirus, CMV, enterovirus. So look at your symptoms. Is it a respiratory illness? Adenovirus is a possibility. A stomach illness, enterovirus is a possibility. Does it have a rash? Then you're talking about herpes or influenza. What kind of rash is it? And you go down the list. So these are our very common ones that we might see. And based on the type of virus that you're looking at, there are different cell lines that we use to grow these viruses in. Because you remember, a virus is an intracellular parasite. So you have to have a cell line in which it will grow. But note that not all viruses grow equally well in the different cell lines. It's not uncommon. It depends on the policy at the lab. They usually try and use either a cell line that grows the widest variety of viruses, or based on the source, they'll apply the specimen to the cell line that would take care of that particular group of viruses. So if it's a skin lesion, and you're potentially ruling out herpes simplex virus, a PMK or a PMK cell might not be as effective as either a HEP2 or HDF human. These are fibroid cells, these are monkey kidney cells, so it depends on what you're aiming for. So in that case, your job as the receiver of the specimen for the viral culture is to make sure that the site, the source, is very well identified. It's not just wound, or it's not just fluid. You need to know where these things are from. Then the specimen is allowed time to grow up on that cell line, and we start looking for cytopathic effects, or CPE, right here. Okay, the CPE are the changes that occur to the cell line, which are characteristic of the type of infection, the type of virus that's causing these changes. Viruses as they feed off of the host cell, the cell will change. And so you can see these are the cytopathic effects that are characteristic of each of the different viruses. Grape-like clusters with adenovirus, a discrete foci in rounded cells of CMV. So you're looking for any cytopathic effect. If you see this type, it is characteristic of that particular type of virus. But you're not done there at that point, okay? You're always going to have some confirmatory test that's going to have to happen, and so you have to understand which confirmatory test would be most likely for that particular virus. A fluorescent antibody test is very common for many of them, I should say. But you can also do heme absorption. You could do nucleic acid testing. You could do IFA. There's a lot of different techniques. And although the gold standard may be something like fluorescent antibody testing, that's not to say that you couldn't use something as long as it was validated, like nucleic acid testing, in order to improve your overall outcome. That would also increase the cost, though. So anyway, these are the most common viruses that we would encounter in the specimen types that we usually collect in this area of the world. So we're going to go through each of them. They're listed in alphabetical order for no other reason than that's just the easy way to do it. Doesn't mean that one is more common necessarily than the other, although that obviously some are very much more common. Okay. The first one that we're going to go through is adenovirus, which is, if you remember viruses from when you were in biology, you know the things that you have to know. Shape, a generalized type of shape. The genome is very important. So those are the things. I want you to know the genome of these viruses, okay? Adenovirus, medium-sized, icosahedral, non-enveloped. Okay, non-enveloped means your immune system can recognize it pretty easily. It is a double-stranded linear DNA, okay? And there are many serotypes. Currently, there are 52 serotypes described, and the key word here is currently, because every year these viruses change and you get new serotypes. Of those 52, only about a third affect humans, and they cause both respiratory and gastrointestinal disease. Most of us think that when we have a virus, it's respiratory disease, but actually as many or more cause gastrointestinal diseases as anything else. So, you might think you ate something bad when really what you had was a virus, okay? As a group of viruses, for adults, only about 5% of the population will be experiencing adenovirus infections as a respiratory disease yearly. But in children, because of their limited, their immune naivete, 18% of children, which is a significant percent, are, there's problems with adenovirus in these kids, cause diseases. It's a 2 to 14 day incubation, so it's hard to necessarily track back who a kid has been in contact with in the meantime, but this particular virus can cause a lot of lost days of school and things like that, especially as you get populations of immunologically naive kids all together. Whereas by the time you're an adult, we all go to work with our sniffles, other people have had them, so you have better immunologic status against it. The fact that it is non-enveloped allows your immune system to get a good peek at it and be able to respond pretty quickly. Now, this virus is actually a very stable virus, meaning this virus is one of those things we worry about, like with little kids, those ball pits and things like that, because this one actually is very stable, so it can remain on surfaces and at different temperatures for actually, it can still be functional even after weeks on surfaces. And so this was like when my kid was little and ball pits were great fun. They'd always get sick when they came out of the ball pit. Now they have, believe it or not, people made $1 million by making the ball pit ball washer thing. So those companies that still have ball pits, they have to wash the balls every night. Now that doesn't help you if your kid goes into the ball pit with another snotty-nosed kid, because they'll still get adenovirus. But if they're the first one in, they go in by themselves, they've been washed and they should be good. The arenaviruses are a little bit more troublesome, not as common, but a little bit more troublesome than the adenoviruses. This is a spherical virus and it is enveloped, so it has a little bit more protection against your immune system. It's also single-stranded RNA, so completely different from the adenoviruses. And it has these little, if you look at the structure here, the little cartoon, these little T-shaped glycoprotein spikes at the surface. Those are the glycoproteins that your immune system is going to recognize and target the immune response against. The disease that's caused by arenaviruses, it's actually a broad range of symptoms. However, there are a couple of significant ones, which will mean that any time that a doctor suspects an arenavirus, you need to move into a pretty high biosafety level. Okay, the two key ones that are really significant are the LCM, or the lymphocytic choriomeningitis virus, which causes an aseptic meningitis. Remember, it's called aseptic because you weren't able to grow any bacteria. Okay, so it causes an aseptic meningitis, and it's pretty contagious. So this particular one, you want to make sure that you're in a BSL-3 whenever you work with that specimen. Okay, even if it's just aliquoting it, you really shouldn't aliquot it out. In remember your routine microhood is a BSL-2. Okay, so even aliquoting this should be a BSL-3. One of the things that I, as a microbiologist, I think should be changed about most microbiology procedures is that CSFs are frequently aliquoted just under the BSL-2 hood, unless otherwise noted, because of things like LCM and Lassa fever, things like that. Now, they're not common, but because of them, it seems to me that CSF should never be aliquoted in a BSL less than a BSL-3 for safety's sake. But nobody listens to me yet. It's not required. So anyway, then the other one is Lassa fever virus. Again, this one's not one that we hear about in the Northeast very often, but it does occur, and we do see it in other areas of the world. You don't get necessarily large outbreaks of it, but when people get it, it usually makes the paper, and that's because this one is actually a hemorrhagic fever. So a hemorrhagic fever means that you do have a high fever, but that there's also a loss of coagulation. So the patient starts bleeding easily, let's say easily, but it can become significant. Nosebleeds, bleeding from the eyes, bleeding in the gut. Any small nick would cause significant bleeding, which can then lead to shock. And it has a 5 to 15% death rate in a symptomatic patient. Okay. Treatments for these, remember this is a virus, so it's not like you can give them antibiotics. Treatment for these is generally speaking supportive and just hope that you can prevent death. So you replace the fluids and you give them blood transfusions and you just hope that they can live through it. Okay. Lassa fever is it's not necessarily more contagious than LCM, but it's a little bit scarier. So we move that to a BSL-4. We don't want people to get hemorrhagic fever by accident, okay? Now, infection with these, generally speaking, is really diagnosed more through molecular or serological testing. This is not something that we would usually do through a viral culture, and certainly not through a routine viral culture, because if this is something that the doctor is suspecting, you should be in a BSL-4. Okay, anytime you have a hemorrhagic fever, you're going to be moving to a better lab. Okay, so the targets that we have, serologically, we're going to target this glycoprotein here, the GP1 and 2, on the arenavirus surface. We're going to look for antibodies against that. This is not one that you're going to see in a large quantity of the population because, of course, it causes significant symptoms. So in this particular case, positive antibodies against a Lassa fever would indicate that you have the disease. Okay. And then, of course, more modern tests would target the genome itself, and you'd look for those genes which are specific to arenavirus, and in this case, Lassa virus, as it were. The Bunya viruses are another group of viruses that have, they can cause, well, actually they are. The whole group is a big problem. So we'll just go like that. This is also helical and nucleocapsid is enveloped, a little bit more protection. It has 3 strands of single-stranded RNA, which would be called a tripartite genome. And it is capable of undergoing genetic reassortment, which means, if you remember from your flu biology, that those genes, if you get a single infection of 2 different strains of the same virus, they can reassort. You can see them up here. They're not necessarily completely linear. They're kind of loops, if you see here. So you have in this little cartoon here, you have 1, 2, and 3 genomes. If you have 2 strains of the same virus infecting a single cell, there is nothing that will manage those genomes as they're replicated to always grouped together, and that's what reassortment is. So you can get a new virion produced that has a different combination of those three strands. There are 12 human pathogens, and most of those are arboviruses. An arbovirus is any virus that is transmitted by mosquitoes or insects. Okay. The groups that are named here, and I have them from here down. Okay. California serogroup, which is interestingly enough not actually found in California. That group is, it actually was mostly found in the Midwest, we'll say, Minnesota, Wisconsin, Iowa, Illinois, Indiana, and Ohio. So nothing to do with California, okay? But it was, I'm not really sure how it got that name. It is grouped into two different diseases, California encephalitis and lacrosse viruses, okay? Lacrosse, Ohio, okay? We have the Cache Valley virus, Jamestown Canyon virus, Snowshoe Hare virus, Tehania virus, Rift Valley, and Inku viruses. These viruses, for the most part, are self-limited. As scary as the names sound, encephalitis and things like that, only about 2% of the people who become infected with any one of these viruses will develop any kind of fatal encephalitis, okay? And then we have the sort of the one of these things is not like the other group, and that's the hantaviruses. I'm sure you've heard about them. They've been in the news. Hantavirus is a bunyavirus, meaning it has the tripart genome. It is helical, nucleocapsid, and it is enveloped. However, it is not an arbovirus. Okay, hantavirus was discovered in the Four Corners region of the United States. And initially it was called the sin nombre virus because in Spanish that means no name, didn't have a name. Once we isolated and characterized the virus, it was understood that it was a bunyavirus and it got the name hantavirus. It causes hantavirus pulmonary syndrome. What happens is the real problem here are rats, okay, or mice, any kind of rodents. What happens is the mice, the rats get into shed, barn, house, whatever, and leave droppings because they're not very tidy. And the patient inhales the virus particles which are in those droppings, whether it's the urine or the stool of the rodent. And a respiratory illness develops, which is very serious and can lead to respiratory failure. Okay. And so that's the basics behind the virus itself. The good thing about these viruses is at this point, without any changes, reassortment always leaves that out in the possible future. We do not have person-to-person transmission of hantavirus, or, well, we know none of the others do because they are arboviruses. Hantavirus, not an arbovirus, but it still doesn't have person-to-person transmission. So that's pretty good. Now there are other hantaviruses that have been found. They're named basically according to the various rodents that carry them, or the areas in which they're found. Other names for these hantaviruses are the Bayou virus, the Black Creek Canal virus, and the New York 1 virus. Okay, and these are carried by these different rats. So the rice rat is found in Louisiana. The cotton rat is this one here, that darker looking one, is found in Florida. And then here's the white-footed mouse. You've probably seen this. This is found in New York. Okay, they're slightly different because, of course, they've evolved with their carriers. Now, you can do, and they can do, cultures for hantavirus, but that is not how it's diagnosed. None of these really is diagnosed by culture, although it's possible. Really, serology is the best method. None of these would be normal. Like, you don't have, 10% of the adult population, you know, that's not normal. So if you find antibody responses against any of these viruses, then you would definitely have evidence that the person has this particular virus. With the exception of hantavirus, any of these other arboviruses, remember only 2% get encephalitis, which is where you really want to know what the cause is. The other cause is self-limited, you know, infection. So most people, we're never going to test them for these. Okay, hantavirus is different. You get a very severe respiratory illness. So that then we are going to be testing you, and we'll look for IgM and IgG antibodies. Generally speaking, method of choice at this point, because we have kits that are cheap and easy, is through ELISA, although we can do molecular methods if necessary. The calciviruses, this is actually a pretty important group in the amount of lost productive time, lost school time, and overall ill feeling that people get from these viruses. These cause and that's because this particular group includes the viruses known as norovirus, otherwise known as the Norwalk-like viruses, and we hear about outbreaks of these every year, in particular in the winter, which is when the uptick tends to happen. But on cruise ships, my goodness, you hear about the devastation that this can cause on cruise ships. The other one that's also on there, doesn't really make the news as much, is the sapovirus, which both between these two together, the norovirus and the sapovirus, these two are include the primary causes of viral gastroenteritis in the entire human population. And the transmission, I hate to tell you this, if you've ever had a virus, you know, enter gastroenteritis, it's fecal oral. So there was poop in the food, okay? This is a small, rounded, non-enveloped, single-strand positive sense RNA virus. Very quick incubation, 1 or 2 days, and you're going to start feeling it. You're going to have nausea, cramps, vomiting, and watery diarrhea. Very uncomfortable. The symptoms are going to be fairly short-lived, but they're going to knock the heck out of you for that time. So 1 to 3 days. And what can unfortunately happen is it can pass very quickly through families because especially if children have it, the diarrhea is everywhere. You've got to clean up. So the symptoms are going to last 1 to 3 days. Unfortunately, look at the shedding, 3 weeks on that shedding. Okay, so viral shedding means that this is still in the stool and it can actually still be transmitted for 3 weeks after you were sick. So your memory is fading. You don't even remember how much you have to wash your hands and all that stuff. The other problem with the calciviruses is that there is no long-lasting immunity to the calciviruses. They kind of do their damage quick and dirty on the interior of your gastrointestinal tract, and your immune system doesn't really produce a very broad spread, a broad or long-lasting immunity against it, which unfortunately is a lot of what you hear about with the gastrointestinal tract. Everything sheds and then you forget it. Okay. In addition, we don't do cell cultures. There's no cell cultures for this particular viral group. Don't have a cell line that really can identify it. We do have RT or reverse transcriptase PCR, but as you know, PCR is much more expensive. So at this point, we have some pretty cheap methods that we can use. There is an ELISA, which means it can be automated. Whenever you see ELISA, remember it can be automated. We like automation. However, most labs don't like to put poop in instruments. It's just a mental thing. So pretty simple test over here. You can see this norovirus card. It is limited to norovirus. It can't necessarily detect any of the other, like this sapoviruses or anything like that, but norovirus is the big one. And you dilute the poop, you put it in there, you can see you get a test line and a control line, and you'll know if it's positive. Okay, I'm sure at this point you've seen these test kits before. They're pretty easy, and it's a lot of mix, put it in, and then wait 10 minutes, and you'll get your result. And if you just I wanted to point out here at the impact of this. Look at this chart over here, and they include the little cruise ship here, which is funny. Cruise ships always make the news, and there can be thousands of people on a cruise ship, so there can be significant effects. But if you look at where the real risk is, it's a long-term care facility. So it's our nursing homes that have the majority of our norovirus outbreaks. These are the people who are high risk for these viruses. Their immunity is low. And unfortunately, when we're talking about fecal oral transmission, it's not the inmates, it's not the inpatients who have transmitted this, it's the workers. So this is important for you to understand the importance of washing your hands. Wash your hands, okay? Because it says here hospitals only 4%, but workers in long-term care facilities, workers in hospitals, you wouldn't have any spread because the patient is bedridden. You wouldn't have any spread if it wasn't for the workers. So making sure that we're careful with that. Then we have the coronaviruses. And the coronavirus, for the most part, when you think of this group, you should just be thinking about common cold. And for the longest time, it was considered that this was a relatively harmless group of viruses. Really only the cold would be caused by it. And that was until 2002. In 2003 when we had the emergence of a new virus, which is called SARS. Okay, this is the name. It gets its name from its look. It's a pleomorphic, roughly spherical, enveloped virus. It is an RNA virus, but it gets its name if you look at this electron microscope picture here. You see these little projections, these little spikes here. They're quite distinct on this virus. And so it was by the person who took the first picture, this was thought to be crown-like projections. And so corona or crown-like, okay, so that's where it gets its name. So again, for the most part, in most people, it's going to cause a cold. In the elderly, the cold can develop into, of course, a pneumonia. Okay, but in 2002, everything changed with SARS. Okay, and there was a worldwide outbreak in 2002, and it started in 2002, but the major impact was in 2003. Here's your map over here, which shows you the impact that was had in the various areas of the world. The key one being China. Okay, China is where it probably emerged initially. You probably are all too young to remember any of this, but it was one of those things where people were wearing masks all over the place, and airports were practically biohazard units. Okay. And we didn't have a test for a while, but it was pretty easy to tell when a patient had this because they were going into respiratory failure very quickly. Okay. At this point, it is easier to track this because we do have antigen tests available. Those meaning like the antigen tests like that we do for monospot and stuff like that. Like it's not a little kit, but we have latex antigen tests available for us to use. Those antigen tests are good for quick and dirty testing, but they're not nearly as sensitive as nucleic acid testing, which takes a little bit longer. But all in all, you're talking about potentially having an answer within 24 hours. Now with SARS, you need it that fast because these patients' their respiratory system can absolutely just drop out that quickly. Okay, this is also important to have these tests because many coronaviruses won't grow in cell cultures. Okay, now it was never really seen as a problem before because it was just the cold, but with SARS, it really is a problem. Okay, So where did SARS come from? Well, likely SARS was a coronavirus that was uh, a an animal virus that mutated and developed the ability to infect humans. And as a naive group, we didn't have, it became much more severe in us. And unfortunately, with SARS, unlike some of the other viruses we have already talked about, human-to-human transmission does occur. It was noted later on in the outbreak that this did evolve, um, and you can get SARS from another human being. You don't have to be around ducks or chickens or anything like that. In the outbreak that occurred in 2002 through 2003, there were 8,000 patients worldwide infected, proven infected, with about 700 deaths. All in all, it's not, if you consider that that's a pandemic, it's not necessarily the worst thing that ever happened, but it was rapidly identified, and so that helped to limit the the spread of the epidemic. The reason it was rapidly identified is because the actual disease was a rapid onset, very, very rapid onset, high fever. People were being scanned in airports all over the world. If you had the slightest fever, you weren't allowed on the airplane. That high fever is followed very quickly by a dry cough and then shortness of breath. And unfortunately, very quickly it devolves into severe respiratory syndrome, total collapse. Okay. It started in 2002. It was contained by July of 2003, and the virus hadn't been detected in humans past that point. But we can still find evidence of it in animal reservoirs. So we do look for it. It is something that doctors are aware of and do look for, but the control of it, the viral levels remain, across the board very low. Now, because this originated in China, which you can kind of tell by the numbers on that map there, you don't get accurate numbers out of China, so we're not sure if there's really no cases of human SARS infection, but the rest of the world that reports, we can pretty much say that. And one of the reasons why the rapid expansion of the disease clinically in the patient is that the viral replication actually, it's kind of exponential. It starts out very, very low. And it's not until the patient is so severely ill that you have enough virus that it's likely to be detected. This is one of the problems with managing this virus. This is an RNA virus, so reverse transcriptase PCR is the recommended method for identification. We can do cell cultures for SARS in particular. Most other coronaviruses doesn't work so well, but SARS, it is possible to grow it on some cell lines, and what you do is get very rapid cell rounding, demonstrating or reflecting that sudden burst of viral replication. And there'll be refractivity and detachment of cells. BSL 3 or higher is required for this viral culture. So again, if this is what they're suspecting, they should be telling you that, and you should not be manipulating that specimen outside of a BSL level 3. Okay, filoviruses or filoviruses, however you want to report it. I like filoviruses myself. This is probably the scary family, okay? And this should be easy to remember. This viral family looks completely different from every other family. Most viruses are rounded. The filovirus is not. You can see that it's a linear or filamentous structure, and the scarier ones have this crook around here. In this particular case, it's looping all the way around. Okay, this is a cartoon of Ebola. Okay, and you can see it has this funky little thing, but most of the filoviruses will have at least some sort of curve. And an electron microscopy is a way to identify them because their curves are usually unique. It is enveloped and it is a non-segmented. Look at that nucleoprotein. It's non-segmented. It curves. It looks, very eukaryotic in that sense. Okay. However, it's RNA. It's single-stranded negative sense RNA. And the two most famous members of this group are Ebola and Marburg. They're they're the only members of this group. Now, Ebola has several strains, and so you'll notice that as we talk about it, okay? Marburg has a little bit less of a curve. It's a little bit more shepherd's hook looking, and it was the first one isolated in Marburg, Germany, or was identified in Marburg, Germany. The nuns who it was isolated in actually returned from Africa sick, and that's to Germany, and that's how they identified it. Ebola is the only other one group. Ebola has a number of sub-species in the group, and they're basically probably the scariest viruses out there at this point that we have. There is no carrier state for the filoviruses. The only kind of infection we have is an acute infection. And so because it's acute, a cell culture is not the ideal way to identify this. Cell cultures take up to a month or more. You can do rapid shell cultures, and that's still, you're talking 3 or 4 days. Okay, a patient can really die within 3 or 4 days. So molecular testing, it's an RNA, so reverse transcriptase PCR is the method of choice for identification of this. You can use electron microscopy as well. Okay. You must use a BSL level 4. So BSL level 4 is where you've got a separate air source, the whole thing, okay? You must use a BSL level 4 required for any kind of culture of this particular virus, okay? There are antigen capture ELISAs to detect IgM and IgG. Those are usually used for monitoring areas of outbreak to try and capture those patients who have been in contact with somebody who's infected, okay? Because you can't just run these expensive tests on people you don't necessarily expect to be sick, okay? Now the fevers, infection of these. This is a difficult one to discuss as far as infection. Transmission of these viruses is actually, it's not necessarily easy, although unfortunately it can become easy. These both cause a hemorrhagic fever. Hemorrhagic meaning that the patient starts to bleed. One of the dangers with the filoviruses, or the only danger really, is in contact with body fluids of an infected person. That's the only way a human at this point can become infected with either of these viruses. A lot of the outbreaks, in particular in Africa, are associated with the cultural practices of how the sick and the dead are cared for. So obviously caring for a sick person puts you at high risk because that sick person is going to be bleeding, they're going to be losing body fluids, they're going to have diarrhea, they're going to be coughing up bloody sputum. And so anytime you come anywhere near that, obviously you're at risk of becoming infected. So this means that you up your PPE requirements to the highest level. You should have on a mask, like a something to prevent splatter, any contact with the eyes, any contact with the mouth or nose. You should have on double gloves in this particular case, and you should have on full gown that comes off before you leave the room. Okay, so a person in Ebola who's been treated for Ebola virus in the United States would have the double entrance, so that you'd have a gowning area and then enter the room. Okay, you also have to consider that when you're dealing with the specimens in the lab, how you're going to deal with it. Outbreaks in Africa, which is where the most of the outbreaks have occurred, really have a lot to do with the way the sanitation. So persons who are ill and they have diarrhea, there is no sanitation in many of these areas. sanitation. So literally, food stalls are set up along roads. Right behind the food stalls are trenches that carry the waste, whether it's food waste, animal waste, human waste, and it just runs down out of the village. So that's very difficult to prevent spread in that particular case. Also, the way the dead are prepared involves cleaning out body cavities, which will bring you in contact with active virions. The virions are active even after the patient is dead. So it will bring you in contact with active virions. And so much of control of these outbreaks has to do with teaching, education of the population about protection for themselves. And is there a way to prepare the dead with the proper PPE? Unfortunately, in many of these outbreaks they're not in cities. This last outbreak that occurred 2 summers ago was in a city, but most of them were in small villages with severely undereducated population, very suspicious population, and so there were cases of them not trusting the doctors and educators and helpers that came to try and quell the outbreak. And in a couple cases, unfortunately, they actually targeted and killed those workers because they thought there was a suspicious thought that they were bringing the virus. So while it's a scary virus, it's pretty easy to not get the virus if you use the proper PPE. And as healthcare professionals, you're trained in how to do that. The flaviviruses, this is actually a very significant viral family because it includes yellow fever. Yellow fever caused one of the greatest plagues in history. In the 1900s, the turn of that century, during the construction of the Panama Canal, thousands of workers died from yellow fever. And if you know about your military history, you would know that it was Dr. Walter Reed of the famous Walter Reed Medical Center who was able to uncover the source of the infection and the fact that this was actually an arbovirus that was spread via mosquitoes when he gave half the soldiers in his camp mosquito netting to sleep with, and the other half didn't get it, which is a little bit unethical, I'm going to propose, but nevertheless, it allowed him to prove that protection from the mosquito protected from the disease. Okay, and then he got the army to send more mosquito netting. Got to always prove to the army why they need it. Okay, what happens with yellow fever and the reason it gets its name, it primarily infects hepatocytes. It'll cause a fever, hence the name, but your liver basically becomes incredibly inflamed, which will cause jaundice, and it can cause also hemorrhage. The 3 to 6 days after that mosquito bite is when you'll start to see those symptoms, and the symptoms are pretty sudden. You get fever, rigor, headache, backache, those kind of things. And then it can progress pretty rapidly to nausea, vomiting, swelling, and then your pallor changes, right? So you get that dusky, livery pallor, you can become swollen, and then you start losing coagulation. Your gums start to bleed, gut starts to bleed. You can even start vomiting black, which means it's just filled with blood, okay? And then, of course, bruising and all that stuff. Okay, pardon me. The mortality rate for yellow fever is anywhere between 5 and 50% worldwide. And if you look at the map for where it affects, a lot of that will be, and here's the map here, a lot of that will be dependent upon the medical facilities in that area. And that 5 to 50%, that death can occur within 6 to 7 days of the onset of symptoms. Okay. Now, urban areas usually have pretty good control of mosquitoes. They aggressively control mosquitoes in those areas. Remember, the mosquito, you know, not to besmirch all mosquitoes, I suppose, although I'm not a big fan of them, but it's Aedes aegypti, which I'm sure you've heard of before. That is the mosquito the guilty party in this case. But in fact, we do have a vaccine for yellow fever, and so we can not for all of these flaviviruses, but we do have one for yellow fever, and it does work well. If you go in the military, you'll probably get that vaccine. Okay, but if you were planning on travel to one of these areas, it's a vaccine you should consider. Okay. In general, diagnosis is frequently done based solely on clinical symptoms. After all, you do turn yellow, so it's pretty easy to identify that. And if you add the clinical symptoms to a travel history, you might not need anything else in order to identify yellow fever. However, we do have antibody testing. We have ELISA and neutralizing antibody tests that are available for diagnosis of yellow fever in particular. Now, dengue is another flavivirus that is present. Dengue is actually much more prevalent worldwide than the yellow fever virus, and this is the map down here for dengue. Okay, same mosquito, many more infected. Over 100 million are infected annually with dengue. And one of the things I want to point out here is it's not shown in the United States, but I really think that that's just PR. We do get dengue in the southeastern United States. It is possible. Aedes aegypti is in Florida, Louisiana. It does exist there. So we do get some cases there. In addition, you have significant travel between the Caribbean islands and that area of the country. So dengue can be sort of imported into that area. Pardon me. Dengue is the leading cause of illness and death in the tropics and the subtropics when you're talking about viral causes. Okay, it's endemic in Latin America, Puerto Rico, Mexico, and the main reservoir is humans. So while it's not a direct person-to-person transmission, you are talking about a mosquito who bites a human. Remember, mosquitoes take a blood meal approximately every 3 days or so. Oh no, that's ticks. A mosquito can take it more often than that. So they take it every, I would probably say 36 to 48, maybe 72 hours. So the mosquito bites a human who's infected and then brings that to the next human that they feed on. Okay, so it's not direct human to human, but it is still technically human to human. It's just through a mosquito vector. There are a variety of different clinical pictures. There are 4 serotypes of dengue, and so one of the problems is if you get dengue once with, say, serotype 1, that doesn't give you immunity to the other 3 serotypes. And so you over time, obviously, you can get coverage, but you have to have dengue 4 times, which would suck. Okay. And actually what can happen, if you get dengue once, let's say I get dengue this year, and then I survive, God bless me, and then I say, well, I already had dengue, I'm going to go back to Puerto Rico and I'm going to party. Oh, great, I'm going to go back to Puerto Rico, but I get this a different serotype. Unfortunately, while my immune response against the first dengue doesn't actually protect me, that immune system can actually lead to enhanced disease with the other serotypes, and I can end up with what's called severe hemorrhagic fever or dengue shock syndrome, where not only do I have dengue in and of itself, but I have this half-hearted immune response against dengue, which doesn't, which actually enhances the disease and leads to a much more broad disease. Now, with dengue, although there's a lot of work on it, there is no vaccine for dengue. Obviously 100 million people infected, that would be a pretty good moneymaker for any laboratory that was able to produce it. But at this point, there is no approved vaccine for dengue. The lab diagnosis, if we find IgM against we're looking for that fourfold increase, or a specific IgG you want, so in other words, against that particular serotype, then that would be a positive. But we also have reverse transcriptase PCRs, because this is a positive sense RNA, single strand RNA, that we can do reverse transcriptase PCR. Now, the other guy that's part of this that we've heard of here in the Northeast is West Nile. West Nile, we know that, and here's our group here. West Nile, we know, is maintained in a bird mosquito cycle. So birds, mosquitoes, there is a reservoir there that keeps it moving. And then we become accidental hosts, so to horses, which if you're in the horse industry, that's actually pretty expensive, via the mosquitoes. So the mosquitoes can also bring it to other accidental hosts. In addition, West Nile has been transmitted human to human, mostly through the blood bank and tissue transplantation procedures that we do have. And so for that reason, we do test units for West Nile, okay, in order to reduce that. They have also seen West Nile transmitted in breast milk. Now, West Nile does still kind of make the news when we have outbreaks, and that's because it can cause an encephalitis. But for the most part, if you have West Nile, you do not get encephalitis, okay? For the most part, what you're going to have, remember, this will be seasonal, right? We know it's in the Northeast now, and it's spreading from the Northeast. But this would be seasonal. This would be a case where in the summer you think maybe you have some kind of summer flu or something like that. You have a pretty good fever. If we did your blood work during that time, you would have a low white count, and you feel kind of just, slow, not so good for a couple of days. For the most part, that's the end of it, and it does not go on from that. In a small percentage, 1 to 2% of patients, and most of them would have some kind of immunocompromised status, but whether they're elderly or very young or they're otherwise ill, all of your patients are otherwise ill, it may proceed to encephalitis, but that's only a small percentage, okay? But we do have this lab diagnosis. We do need to find this in particular in our donor population. And we just basically look for IgM because it's not endemic to this area. So if you have IgM, it would be pretty evident that you've been exposed to it. And then if for encephalitis, if we suspect it's West Nile encephalitis, we would look for those antibodies specifically in the CSF of that patient. And we do have commercial kits available for us to do that. Again, there's not that many cases of encephalitis running around the world that you need to necessarily keep this kit on hand in a lab. So for a lot of labs, this will be a send out. The other diseases caused that are flavivirus include Japanese encephalitis and St. Louis encephalitis. These are viruses that also have a significant, interestingly enough, a significant impact on the equine population. And so there are actually vaccines that have been approved in horses, haven't been approved for us yet. And so these ones can cause, again, in humans, only a small percentage actually develop encephalitis. Okay, it sounds like if I get this virus, I'm going to get encephalitis, but that's not true. In most cases, encephalitis only develops in those patients who are most at risk for it. The elderly, if you have another underlying disease, like for example, cancer, or maybe you have some other immunocompromising status, like an alcoholic would be higher risk, a drug addict would be higher risk, a homeless person would be higher risk. So those things would all include, and the very young, of course. So most of these are arboviruses, but then we have our dreaded friend Hep C. Hepatitis C is also a flavivirus, so it's single-stranded, positive sense, single-stranded RNA. small icosahedral envelope. We know that already. But this specifically tracks to the hepatocytes of the liver and causes hepatitis. It still is a major problem. It's one of those sort of underreported diseases because it does produce a latent infection that can last for years, and it's upon its reactivation that it can, even as a latent infection, it can be causing sort of low levels of damage to the liver over time. Generally speaking, it's with reactivation that we see that full-blown liver disease that can be very hard to treat. These days, however, they're actually using the word cure for some of their treatments with hepatitis C, some of the drug regimens that they're on. This would be a first. We don't really have viruses that we cure. Okay, so hepatitis C never was able to be cured before, but when we're using that kind of word, that's pretty encouraging. Here's the hepatitis C that we talk about. Remember, unlike other flavies, it is not an arbovirus. You do not have to worry about mosquito bites. However, we have a very large number of carriers, 179 million carriers with 4 million infected new infections every year. Okay. The acute infection will progress pretty quickly to a chronic, or not necessarily quickly. It progress to chronic infection in anywhere between 50 and 90% of individuals. This is very difficult because some people never know that they were infected. And it is one of the more important causes of liver disease and end-stage liver failure, as well as liver cancer in the world today. Okay, transmission is primarily through contaminated blood or blood products, not an arbovirus, not mosquitoes. Okay. We can diagnose hepatitis C. Mostly we do it through the screening serologies that we have. So we have an EIA or ELISA. They're the same thing. Sometimes I leave off some of the letters. EIA or ELISA, they run pretty much the same way. Immunoblots are available. I think those are less popular to do. And then we do have PCR. PCR, well, we have reverse transcriptase PCR, and we have branch chain DNA testing, which is another form of PCR. So anyway, and what we do with those two tests, they're generally not used for screening. Those are usually used to quantify viral loads, so you get an actual quantity, and you can monitor the viral therapies that you're using to treat the patient. So the molecular tests, the reverse transcriptase PCR and the branch chain DNA technology, both of those are generally used in order to monitor therapies on our patients. So you will see those tests in the laboratory, but it's the serology test, the enzyme immunoassay or the ELISA enzyme linked immunoassay or the immunoblots, which usually are there for screening of our patients. Okay, and the great thing about ELISA, about these immunoassays, is that they can and have been automated, which makes the flow in the laboratory much better. Then we have the hepaviruses. The only member of the hepavirus is hepatitis E virus. The hepatitis E virus we talked about before. This is a kind of an interesting virus in that it's probably present in more people than we know, but it's really only in pregnant women that we have to really be very, very aware of it. This is a small, non-enveloped single-stranded RNA virus, and it causes gastroenteritis for most people. You can see the geographic distribution of this virus, over here in this chart. Southeast Asia is the biggest hit, followed by, I would say, call that Northwest Africa. Although you can see Central America is also affected. This is actually a virus that is associated with poor sanitation. Okay, that's what we're talking about when we're talking about hepatitis E. Um, Generally speaking, you're going to get gastroenteritis. It is acute. You will not be comfortable, but it'll be self-limited. Okay, so within a few days, you will be done with your stomach illness. Okay, the biggest problem, and we've talked about this before in other classes, is that pregnant women who are exposed to and get this disease in their third trimester have a very high fatality rate, a 30% fatality rate. So that is quite high, and it's an interesting risk for women. And it's one of the reasons why in the United States, if you go through prenatal care, they want you to not travel to these endemic areas. Okay, so you might not have a trip planned to Southeast Asia or Northwest Africa while you, and actually they're really going to say don't travel anywhere even close to these areas in your third trimester. But in the United States, you might have a trip planned to Central America, and you would be advised by your doctor not to go there. Okay. One of the things you should note is that these are the areas of the world with probably some of the worst sanitation that is there. Not all of it is bad, but in the areas where it is bad, it is really bad, is my point. Okay. Diagnosis with this one is through serologies. We generally, they haven't really worked on perfecting that cell culture clinically because in this area of the world, it's not a major issue except in pregnant women, okay? And because it's relatively new to the research area, we really don't know if lifelong immunity is produced. Again, I'm not going to test you with this one to see if you get sick again. Okay, so it is possible with many GI viruses, we know that you don't get lifelong immunity. So if we just go by that rule, you probably don't get lifelong immunity. So it's not like your travel would be reduced as a pregnant woman in just your first pregnancy. This would be a policy in all pregnancies. Then we have the hepatinoviruses. The prototype virus of this particular family is hepatitis B. It is a pleomorphic enveloped, partially double-stranded, not completely, but partially double-stranded DNA. And this has a very interesting form of replication in that it replicates through an RNA intermediary. Okay, so where's my pen? Here it is. In this chart here, it's kind of showing how it's producing. You can see as it uncoats inside the host cell, here's your viral DNA. That gets the viral DNA is actually integrated into the host genome, which means that RNA will be produced because that's what host cells do, right? From DNA, they produce RNA. And from that RNA, eventually you'll go through this RNA intermediary. The virus will use that as a template to produce its DNA strands, which will then be re-encoded and sent out through the cell membrane as normal. This is quite a stable virus, meaning that it can last on surfaces and in a variety of temperatures for quite a long period of time, making those areas important to clean so that they're not infectious. One of the highest infected groups used to be emergency responders or first responders to, for example, a car accident. Even if you're not directly dealing with the patient, if you're trying to remove the car, there might be blood or other body fluids on the car. Even dried, they can remain infected. So first responders are actually one of our largest groups becoming infected with this virus until a vaccine was developed. A vaccine exists and it is very effective. Even with that infection, 400 million people are infected worldwide with about 50 million new cases annually. The vaccine is available and is used in first world countries, but its use in other countries is not as well developed. Okay, that's where we got to get the WHO on. With the disease case, or I should say, first we'll say transmission. So we know that transmission occurs through contact with blood or body fluids from infected patients. You can also get perinatal or vertical transmission, as well as sexual contact, any body fluids, and you can see transmission. The other place for healthcare workers is a needle stick, which is still contact with body fluids. Okay. The incubation period is fairly long, 1 to 3 months, and it can be even longer. And unfortunately, there are a lot of asymptomatic cases out there, which only exacerbates the transmission to other humans. Lab diagnosis then becomes very important. We must be able to rule out other causes of hepatitis in our patients. And part of that is being able to do these serology tests, which are what we use for diagnosis of hepatitis. We really don't use cell culture, okay? Because remember, it's in the hepatic cells, so you're not going to do a liver biopsy on everybody just to rule out hepatitis. However, if you do the serologies, there's a number of tests that are available for testing. The surface antigen is the most reliable marker for identifying infection. And please, when you're going through the hepatitis test, please keep track of what you're looking for. If it says anti in front of it, that's an antibody. Sometimes, however, it is listed, this particular one will be listed as HBCAB. So keep track of what you're really looking for, okay, so that you understand how to answer the questions, okay? The surface antigen obviously would not be there unless you had an infection. That means that's actually a part of the virus, and it couldn't be there unless you actually had the infection. Okay, and that marker actually is usually evident in the blood before any liver damage is apparent. So if we can find that early, we can help reduce we can start treatment and hopefully reduce liver damage. And that'll be there in the acute phase, it'll be in the chronic phase, it'll be there the whole time, okay? Then we look at the antibodies. The first one that usually appears is the core antibody. So that's what the C stands for, the core, and that's actually usually there in the acute phase. The surface antibody, that actually usually comes a little bit later, and it indicates either convalescence or developed immunity. So if you guys had the vaccine, you will have the HBS antibody in your blood. Okay, so you can't use that as a marker for infection because many people have been vaccinated, and we expect that. That's why the antigen has to be used as a marker for infection. The E antigen is or envelope antigen. This is actually a marker for the rate of infectivity. Obviously, it's an antigen, so if it was not there, if it was there, that would be a good marker of infection. But actually, we use that as a marker of infectivity. Those patients who demonstrate this antigen in their blood are usually highly infective, and they are usually chronic carriers. And then, of course, we do have nucleic acid tests, so we can test directly for HBV DNA. We have direct nucleic acid testing, you get a PCR, there's lots of things you can do, and that usually indicates, if that's present, it indicates active viral replication, which would mean a high rate of infectivity. So we can use these last two, the E and the DNA, really as markers of where the patient is in the infection. Do we have the patient early on in the infection when they are, or during a relapse of the infection, when the virus is actively replicating and causing and spreading to more hepatocytes. Usually be a pretty good indicator of increased liver damage as well. Herpes viruses. Okay, the herpes virus contains 8 viruses. You got to know them all, and you got to know you've heard of them all before. But it contains eight viruses that cause havoc throughout the clinical world. Okay, it's a fairly large virus. It is the large enveloped virus, and it's a double-stranded DNA. A double-stranded DNA genome that is surrounded by these proteins that basically it's called the tegument. So you have the genome in the center of the virus. Surrounding the genome is a nucleocapsid. It has this protein coat surrounding it, and then surrounding that protein coat is I'll call it a structure. It's an asymmetric structure, which is why they show it in different colors in this cartoon. Of all these different materials, they're fibrous-like materials that surround that nucleocapsid, and they're between the nucleocapsid and the actual outer capsid that contain, there's about 20 different proteins that are part of it. And what they will do is they will become, when they are uncoated inside the host cell, they will help to participate in viral replication. So this particular virus actually brings a whole bunch of proteins with it to do the job once it gets into the next host cell. And this is a unique feature to have so many different proteins that it brings with it to the next cell as it infects it. Okay. These viruses, there are 8 of them. There are animal versions of the herpes virus, but they don't infect humans. The only exception to that is a virus called the herpes B virus, which is not included in these 8. Okay, the herpes B virus actually is it infects primates, non-human primates. Monkeys, generally speaking. The only humans who have become infected with herpes B virus were basically animal workers or people who worked with these primates, whether in research or in zoos or something like that. And the animal became sick, and one of the things that primates do when they become sick is they throw poop around, and so people get sick. And unfortunately, for all these cases, you develop a severe and usually fatal encephalitis. So that is a virus that's out there, but it's actually not. You're an accidental host. It's not normal. The other viruses that are in here include herpes virus 1 and 2, well-known viruses that cause ulcerations, highly infectious ulcerations, these viruses are all able to establish latency. In the case of herpes virus 1 and 2, the latency is in the sensory ganglia, as well as which then produce mucous membrane and skin lesions, and potentially central nervous system disease because it can move backwards on the nerve. But basically, the herpes virus is an infection of the nerve. Then you have varicella zoster virus, also a herpes virus, and that causes chickenpox. You've heard of that before. We're going to talk about these a little bit more. Human herpes viruses. You have 6 lymphotrophic viruses, you have EBV, you have CMV. We're going to talk about these all a little bit before, and then human herpes 8, which is cause of Kaposi's sarcoma. Lab diagnoses of all of these, there is a gold standard, and it's cell culture. Okay. Now, the success of a cell culture will depend upon the quality of the specimen submitted. If you're talking about a lesion, like in the case of herpes 1 and 2, or even varicella zoster, The collection method of the lesion is actually quite painful for the patient, in particular in herpes 1 and 2. You actually have to puncture the lesion and collect the fluid underneath the lesion. To collect that fluid and get it, you want to get all the way down to the base of that vesicle. You could do it with a swab, but you have to pull off the lesion, which is quite painful. And it has to be inoculated onto cells within an hour. Or placed it. You can place it in viral transport media and refrigerate it, and you've got more time. But it'll grow fine on the cells once you get them. And in modern techniques, we can do a shell viral where you can grow the virus up for a few days and then do nucleic acid testing once you start seeing the cytopathic effects. Okay. Luckily for us, we do have direct antigen testing for herpes, so it's usually with nucleic acid amplification, some kind of PCR and or serology, some kind of paired system in order to test the direct specimen from that patient. And you can see here, this is one of the ones of the tests that is available for fluids. This would be for specific fluids that you get from the patient. Okay. Now I'm just going to go quickly through some of the things you need to know about each of these. Varicella zoster virus is chickenpox. That's what it causes. Okay. It is a two-phase primary infection where the patient has usually the infection starts in either the eyes or the upper respiratory tract and then travels to the lymph nodes. And so you are infected at that point. You're not going to feel very well. About 4 to 6 days after the initial infection, this is a T cell mediated immunity, and they will enter the bloodstream. The T cells actually become infected, and they'll enter the bloodstream, and you'll get that viremia. That's the primary part of the infection. Once those T cells, those infected T cells, enter the liver, the spleen, or other organs, you're going to get a second round of viremia. And it's really not until that second round, about 14 days after the initial infection, that you start to develop the rash and the pox. Okay? So these lesions will develop, and then they're kind of just red marks that crust over in a couple of days, and it usually takes about 3 days for them to resolve. Okay? From that skin lesion portion, the virus is going to set up latency in the sensory ganglia. Okay, similar to herpes virus 1 and 2. And that latency can be reactivated at a later date. In reactivation, you don't usually have this, obviously that primary phase isn't the same. You get these lesions that are usually much more painful than the first time that you had it. Reactivation generally will occur even in immunocompetent people. You don't have to be sick, but it usually occur over the age of 45, and it can be quite painful and debilitating. And unfortunately, it can last as long as the original infection, 3, 4, even 6 weeks. Has not been uncommon. And the pain comes from the fact that the infection this time is centered in that neuron, and so your neurons are being triggered all the time. Okay. Usually you don't need to have a lab diagnosis. They can diagnose this with clinical symptoms. Doctors know what it looks like. However, cell culture can be done, and what you'll see on the CPE are inclusions as well as giant cells. Of course, that doesn't differentiate it from others' herpes, in particular the herpes simplex. So that's going to have to be, you're going to have to find those viral antigens. Usually fluorescent antibody is what they're going to use. Okay. And they have shell vials. Shell vials, when you grow it up for like 3 days and sort of you centrifuge the specimen onto the cells and grow it up quickly, and then do the antibody testing at that point, which will reduce the overall length of time that the specimen is out for diagnosis. Our next one is EBV. EBV actually was discovered during a search for the cause of Burkitt's lymphoma, so we know that it's associated with that, and it is transmitted from person to person through the saliva. Okay, the disease primarily affects the initial disease, the acute phase of the disease, primarily affects teens and young adults. That's when you come in contact with it. And the symptoms are fever, sore throat, headache, malaise, and fatigue. But it'll be associated with lymphadenopathy, so swollen lymph nodes, and splenomegaly is, at least to some extent, also present. And when those two are present, you're probably looking at mononucleosis, which is what we call that primary disease. Remember that the test that we use to detect that in the beginning is the the non-specific heterophile antibody, otherwise known as the Paul-Bunel antibodies, and those will appear early on in the disease. Okay, I'm not going to go through how to identify this all, but here you see the antigens and the antibodies that are present at various points in the disease state for EBV. Then we have CMV, which is it's actually usually non-specific, sort of not very dangerous disease in adults. However, if a mother contracts this while pregnant, it can be a very common cause of congenital birth defects. And for that reason, this is included in a serological panel called the TORCH panel. TORCH stands for Toxoplasma, Rubella, CMV, and HSV. The TORCH panel basically covers those childhood illnesses that where we can see birth defects and changes in development for the kids. So you'll usually get that ordered on young kids, hopefully. Okay, but in adults, the disease that it causes, it can actually look a lot like infectious mononucleosis, right? So sort of non-specific fever, lymphadenopathy, things like that. But unfortunately, in an immunocompromised patient who receives an organ transplant, including a blood transplant, this can be a very serious disease, very serious disease. And so we do test for CMV in donor units and in organs. If a patient has, if a recipient has already received, already has CMV, they can receive blood from a CMV positive unit. Usually they're not immunocompromised enough to really for it to be a problem. However, all organ donors are immunocompromised, and we're going to exacerbate that by the treatment of them. In those cases, you really do want CMV negative units as often as possible. And one of the ways that we can do that is by neutralizing the white cells in the unit if possible, so that any virus that might be in there is not, the virus isn't able to escape and replicate. This particular virus is usually, it can be, obviously you can detect it using a viral culture, but we also have serologies and direct antigen testing as well as nucleic acid testing available. Now, one of the things that you do have to know about this is the CPE, which is unique for CMV. This virus will grow. We know that it'll grow in white cells, but it also grows very well in fibroblasts on a cell culture. And the CPE that develop in those fibroblasts is very characteristic, and it's this these owl eye inclusions that develop inside the fibroblast, and you can see them here. Okay, these owl eye inclusions are characteristic of CMV. Okay. At this point, CMV has been fully automated. We do use it for donor units, so we do want it automated. For most of the population, we don't really care if you've had it or not. However, when you're talking about treatment for various types of cancer and for those diseases that leave you immunocompromised, then we do need to know what your CMV status is. Orthomyxovirus, probably another famous virus for rather mundane reasons. This is the family that includes flu. It is a pleomorphic spherical enveloped virus, and it contains a segmented single-stranded negative sense RNA genome. This actually has the greatest number of serious acute illnesses associated with it compared to any other virus in any other group. The serious illnesses can be counted just in the United States with greater than 200,000 hospitalizations annually and greater than 30,000 deaths annually. Okay. At this point, there are three types of flu or subtypes, I should say, of flu known to infect humans, and those are types A, B, and C. Okay, easy to remember. And from those, C is probably the mildest. Most influenza C viruses are subclinical, meaning the symptoms are mild enough not to lead to medical intervention. You might not even realize that you were infected with C. Although in working in a virus lab, I did have influenza C at one point. I would call it less than subclinical. It was knocked me through a loop. And we have had years where a pretty vicious C was circulating. If you do have a C that can cause symptoms, it generally will be a more widespread outbreak, and that's because less of us are immunologically competent against it. Okay. These different subtypes can be differentiated by the antigenic differences on the matrix proteins as well as the nucleoproteins. Okay. A is the type A, which is where we see the most severe disease in humans. Type A is further subdivided by the major surface glycoproteins, hemagglutinin and neuraminidase, that we see on the surface of the flu. Okay, this virus can infect a whole different classes of hosts. It can infect swine, birds, seals, feline, horses, as well as humans. Okay. Now I keep losing my pen. The two major glycoproteins on the outer surface are not only glycoproteins, but they're also means of attachment and disease. They actually cause some of the symptoms of the disease in the human. The HA, or hemagglutinin, this is a rod-shaped spike that actually allows the virus to attach to the sialic acid-containing cell receptors on the host cell, and so it allows it to actually initiate the infection. The neuraminidase is more mushroom-shaped than rod-shaped, and those spikes on the surface actually allow the virus to release mature virions after replication, and so the neuraminidase is what is going to allow the virus to move through the mucus to adjacent cells. At this point, there are 16 different hemagglutinins and 9 different neuraminidase, and so when you see the lists of the virus, you're going to see the viruses named by its HA and NA designation. At this point, we know that hemagglutinins 1, 2, and 3, and neuraminidase 1 and 2, these are currently circulating in human populations. Not only is this possible to transmit from animal to human, it is possible to transmit from human to human, which makes the outbreaks just that much bigger. Okay. The combination of these two can lead to an increase in pathogenicity. So for example, H3N2 is a highly pathogenic strain with a greater mortality than some of the other ones. Is it an H1N1? You know, those are the different combinations that you'll see. The reality is that when you have a new and different virus for which there is no immune response in the population, you will see a larger outbreak, maybe not necessarily increased pathogenicity or increased virulence, but definitely a larger outbreak. And if you've got the flu, it stinks. You've got the flu. Okay. Now there are two terms that you need to understand because they specifically guide our thinking in epidemiology of flu disease, influenza disease. And those are antigenic drift and antigenic shift. Okay. These are two things that affect the evolution of this particular virus. Okay. Antigenic drift, remember this is an RNA virus, and we've talked about the difference between RNA and DNA before. RNA has a higher rate of mutation than DNA. It allows more errors to be introduced into its sequence without being changed. Okay. In antigenic drift, what you have is when an original virion enters the host cell and replication occurs, there's some kind of mutation, one or more mutation that occurs in the, generally speaking, it'll occur in those hemagglutinin sites, because those are the sites that allow it to enter into the host cell. And so when this new virion is released with its mutation, the changes at that hemagglutinin, which is what your immune response is directed against. See the antibodies here? They're preventing, they're protecting your cell, they're preventing attachment, preventing initiation. But if the hemagglutinin has been changed by that mutation, which occurs very easily with RNA, the antibodies can no longer bind and you have no more protection. That's the reason why you have to get a flu shot every year, because you don't get long-term immunity. The flu is constantly changing because it's an RNA virus, and because it's constantly changing, you do still have antibodies, but they just don't work anymore. Then we have the major problem with influenza epidemiology, and that's antigenic shift. This requires a very specific thing to happen. Pardon me. In antigenic shift, what you have is a single host cell has been infected with two different, here's one, here's two different strains of influenza. Remember, both strains are going to enter the cell, initiate infection. Both strains are going to undergo replication. So at the end of the infection, I think it's a little hard to see in this picture, but in the end, you see that this, where the two red and the one blue has an entirely red capsid and hemagglutinin. The two blue, one red has entirely blue capsid and hemagglutinin. Okay, so look at the entire virion. Once in the host cell and replication occurs, reassortment can occur where those genomic segments, there's I believe it's 8 genomic segments. Those genomic segments can reassemble in a new virion in a totally new and different organization, so that the genes that enter it are not the same combination as either of the original virions. And so what you end up with in this case, if you look at it, you have a red capsid with a blue hemagglutinin, which is neither one of these had that. And your antibodies can't respond to that. This is a new, totally new and different virus particle. You will spread this into the environment. Your other cells will be affected by it. It'll prolong the disease in your own body. And so you end up with a novel virus particle. This can occur, generally what happens is this occurs in animal infections, and this virion develops the ability to infect humans. Most animal influenzas can't infect humans. It develops the ability to infect humans, and you end up with a significant human disease that year or the next. Testing for the flu can be done, it can be done with a viral culture or with direct detection of nucleic acid. We also have antigens, antibody testing, serology testing that allows us to rapidly detect flu in specimens. We do have rapid tests now. There are antigen tests that look for flu off of nasopharyngeal swabs that are taken from the back of the nasal cavity when the patient is displaying symptoms. And if we get that specimen down to the lab, we have pretty rapid testing for that. So we can identify, we could give a result for that in a few 15 minutes or so. The virus will continue to be shed for up to three to 5 days after the onset of symptoms. So you are infectious for the entire time. And so we want to keep you away from other people so that you don't keep spreading that. And we want people to use proper hygiene so that they don't spread it. The key thing is don't go to work if you have the flu. Okay. And the symptoms of the flu, this is not a cold. The flu, most people who say they had the flu, they didn't have the flu. The flu is something that will knock you on your butt. Okay, you will have very severe. You'll have a higher fever. You'll have all the symptoms of a cold, but you'll also have pretty intense muscle aches that are pretty characteristic of the flu. You can see here in this picture from the CDC, I believe, that we can see the different outbreaks of the flu over the years. Okay, there are certain countries that deal with flu outbreaks and epidemics on almost a yearly basis. So there's a different outbreak every year, but some of them are much more significant and more widespread than others. And we can usually track them to some kind of conversion from an animal influenza that was able to develop the ability to infect humans. And you can see that in these three cases, the 1918, the 1957, and the 1968 outbreaks. Okay. In 1889 and 1900, we also had pretty significant outbreaks, although obviously our science, our technology was not as advanced then to be able to deal with viral cultures and identification and all that. In 1918, however, we've been actually able to go back and retrieve specimens from those patients. Thank God for the U.S. Army, they save everything. And so they saved blocks of tissue from their patients, most of whom were 18-year-old or so young men who were fighting in World War I. And so they kept their specimens in parafilm or formalin blocks, and we were able to go back and characterize the viruses. We didn't really have the technology then, but we were able to characterize the viruses then. And we found out since that it was an H1N1 virus, which is kind of interesting because from what we know about that particular combination, it's not particularly virulent. But obviously in 1918 with the Spanish flu, it was particularly virulent. A person could be perfectly fine in the morning and dead later that day. It was so virulent, okay? It was so widespread. In 1957, it was an H2N2 that was called the Asian flu. And that it had different characteristics you can see there with the genetic genes that were present. 1968 Hong Kong strain, the Russian strain in 1977. We had a swine flu that wasn't particularly virulent a number of years ago, about 5 years ago. So each of them will get their names, and they're trying to use the H1N, the HN designations now because I guess it's not politically correct to associate it with a particular place. Okay. But these were just larger outbreaks that spread outside the borders of the originating area, and in some cases became pandemics. In most cases, in these cases, they did come at least very close to being a complete pandemic. Papillomavirus is another fairly well-known virus family. that is able to infect many species, so it can cross over from species to species. This is a small, non-enveloped circular double-stranded DNA virus that's known to cause warts. Papillomavirus causes, it has a cutaneous or mucosal tropism, so it goes toward the skin or the mucosal surface, and it causes basically an over replication or an uncontrolled replication of those particular tissues where the infection occurs. Okay, depending on the genotype, the tropism will be slightly different. So some viruses, some papillomaviruses, some strains are particularly attracted to, say, the squamous epithelial cells. Some of them are attracted to the epithelial cells of the cervix or the larynx or whatever the particular tissue is. So for example, we have an HPV1. This is usually the common cause of plantar warts. So we usually find that on our feet. 4 common warts of the hand. 6 and 11, genital warts. 16 and 18, cervix. And those are the two, 16 and 18, very significant in cervical cancer. Okay. Now, 16 can also be found in other tissues or pharyngeal tissues, and it's also associated with penile cancer in men, but it's more famous for its cervical tropism. The papillomaviruses have not been cultivated in cell culture, and because of that, it makes producing any kind of specific antigen, a typing antigen, difficult. Because then you don't have any antiserous. You would need to have it in a cell culture in order to do that. And of all of the papillomaviruses, there are over 200 genotypes present just based on DNA sequencing. 30 of those, more than 30 of those, are sexually transmitted genotypes, which have actually a pretty well-established role in cancer development. HPV is actually the most common sexually transmitted disease in the United States, and that's because it is highly infectious. It's not necessarily the fluids that you have to worry about, it's the skin. So it's skin-to-skin contact is all you need. You don't need to have fluids present for transmission of this virus. Generally speaking, we use histopathologic or cytologic exams of some kind of biopsy, or cells collected in some way that way in order to diagnose this. But there is nucleic acid testing available, okay? And in addition, we do have a vaccine that is currently available against 16. I believe there's a new vaccine that includes 16 and maybe 18 as well. But there are vaccines out there which are they're the actual outer capsid. It's an empty capsid that you're actually injecting into the patient to develop an immune response. Now, whether that immune response will be enough to protect you, we'll see as it goes forward. And even with 16, 18, those high, most of the people who get those, the infection will clear on its own within 2 years, and you don't develop cancer. However, we can track the cancers back to those types. So if you do end up with cervical cancer, it'll probably mean that you did at some point have HPV. Oh, you were infected anyway. The paramyxoviruses. The paramyxoviruses include a lot of the diseases of childhood, including measles, mumps, parainfluenza, RSV, those ones. And then we have a couple of new ones that are relatively new to this particular family in our importance. And so that's the metapneumovirus and the nifavirus. These are spherical enveloped viruses with a non-segmented RNA genome. And what they all cause is basically respiratory disease. Okay. Probably the most common one is parainfluenza. Parainfluenza is very important disease. Most of these are diseases in children, and it causes croup. Okay, most parents have had to deal with croup at some point in their newborn or young child's life, and it's a tough disease to deal with, but it generally isn't crazy severe. Um, it's just a rough upper respiratory infection with a pretty significant cough. Parainfluenza has 4 subtypes, 1 through 4, and depending on which one your kid gets is how severe the disease is in your kid. The most severe parainfluenza is parainfluenza 3, and it generally will require hospitalization if your kid ends up with that. They'll have quite a bit of difficulty breathing. 1 is the most common, causes croup. 2 is pretty mild, and so is 4, pretty mild. How is it acquired? Usually inoculation through the mucous membrane. So it's, human to human, fomites, aerosols, either one can cause your kid to get this. And parainfluenza is pretty stable, can live on surfaces up to 10 hours. So clean, clean, clean. That's what you do when you have a kid. How do we identify parainfluenza? We do cell cultures on this. We use primary or continuous cell lines with a confirmation using IFA or some other antigen detection method in the laboratory. Okay. As far as serology goes, because this is pretty common, you'd want to know which type and things like that. So the cell culture is more highly recommended and more accurate for what's going on in your kid right at that moment. RSV, a very common cause of bronchiolitis in young children, and it is actually the most significant cause of acute lower respiratory infection in children under the age of 5. There are more than 100 deaths annually in the United States because of RSV, and these are kids under 5, and between 60,000 and 100,000 hospitalizations annually. RSV has a unique surface protein called the F protein or fusion protein. And what that does when it infects the lungs of the child or the lower respiratory tract of the child, it causes the host cells to fuse, which is another means of allowing the virus to move from cell to cell. Instead of leaving one cell and entering the next, just fuse the 2 cells together using the F protein, and you end up with what are called syncytia, S-Y-N-C-Y-T-I-A. Those syncytia are characteristic, and they're the hallmarks of RSV, okay, which stands for respiratory syncytial virus. So how do we treat that? Remember, these are kids, so they, by definition, have fairly naive or very weak immune systems. So RSV immune globulin, which is a concentrate of antibodies against RSV, is used to protect those newborns who are at risk, like newborns with low birth weight or other some kind of underlying respiratory disease. It's used to protect them, and then if the child becomes infected, they can also be treated with RSV immune globulin. Diagnostic testing is done, it can be done using cell culture. More commonly, we have a direct antigen test where a nasopharyngeal swab or a bronch wash is generally really what's used, because little kids don't produce sputum, so we look for that bronch wash, and there's direct antigen testing that can be done off of that bronch wash. Then we have measles, which is, generally speaking, an acute self-limited disease characterized by parotitis, which the parotids are salivary glands, and so your salivary glands sort of under and below and to the sides of your tongue, below the lower palate of your mouth, become inflamed, and they can become enormous so that the child's entire chin sort of develops into a neck. And they get very high fever and fatigue, and those salivary glands are incredibly painful. Okay, and that disease was a common illness of kids before the vaccine was developed. Okay, but it is transmitted from person to person through droplets. That was mumps, and then we have measles. Sorry if I think I said measles. That was mumps. The parotids was mumps, and then we have measles. And I have them in the opposite order on the slide. Sorry about that. Measles is it's an acute generalized infection or systemic infection that has a characteristic rash, which is referred to by the Koplik's spots that the doctor can see, which are these bluish white spots that have a red halo, and they're found in the buccal or the labial mucosa, which is the inner lip and around the lower molars in the mouth. That's a pretty unique characteristic for this particular virus. Now, one of the problems with measles is our distance from it. We have had the MMR vaccine protocol in place in the United States and in Europe, where you were protected against measles, mumps, and then the RS rubella since for many years now, and then the number of cases have decreased in our two areas 99%. So we don't really have the experience, the personal experience with measles that we used to. But measles is actually still, it's the number 3 killer of children in the world. Okay, number 3. Okay, it's not just a rash and a fever. It is a systemic infection, very high fever, and it can lead to death if you are unprotected. Here we go. Let me find the in this map here. You can see that there was a measles outbreak in 2013 that occurred in Europe, the United States, Australia, and I keep losing my pen. And up here you can see in the Netherlands. You can see the number of cases that existed. These cases were only for children who had not been vaccinated. So these are people who opt out of vaccinations and become, their children then become potential victims of this disease. And you can see the numbers in Wales alone, 1,200 people, unvaccinated people contracted measles. Okay, that was the largest outbreak or place where the outbreak was in the Romanian capital of Bucharest, 3,000 cases. In our own country, California was the state of origin. The cases occurred, a variety of cases across the country, but the initial case, the index case, was actually found. These were all children who visited Disneyland, and Marin County, California, the parents had opted out of school vaccinations, and 28 cases in Marin County existed. And this can be a fatal disease. So remembering what the purpose of the vaccine is, that is to protect your kid from death, not just from inconvenience, but from death. So remembering that this is actually a very high, has a very high mortality rate for this. Diagnosis for either measles or mumps is actually done through serology with the patient's serum. We can do cell cultures, it's possible, and we do have nucleic acid testing if you want, in particular for measles. But we can do serology, and we can look for IgG and IgM levels in the patient. If you do suspect that the patient has an active case, then you want to look for, you want to take the proper specimen and probably do nucleic acid testing. For measles, you want respiratory or throat specimens, since that's the primary origin of the infection. And you would do nucleic acid detection on those specimens. For mumps, you would want a buccal swab, which would be basically the inside of the cheek, like in the lower cheek. You would want to swab there. You pick up the most viruses there. But both of those viruses do shed in the urine, so you could do a urine for either of them as well. Basically, what you're going to do is check with your reference lab, because based on the kit that they use, they'll give you the acceptable specimens that they can use with that kit. Some fairly new viruses to the paramyxovirus family. The metapneumovirus is fairly recently discovered. This is closely related to the RSV virus. At this point, still difficult to grow in cell culture. It's less common than RSV, but it's actually more common than parainfluenza, so that makes it medically relevant, okay? And it causes bronchiolitis and pneumonia in infants. In older adults, it'll cause a lower respiratory tract disease, so it's something that we do have to keep an eye on and remember that it is something that we have to look out for. It is a very slow grower at this point in cell culture, more than 2 weeks before you see any kind of cytopathic effects. So at this point, they have to find either a better cell host for it or use the nucleic acid testing. There's also viral RNA, the nucleic acid testing for the viral RNA, and that's pretty widely available at this point. Then the Nipah virus is another recently discovered virus, which is capable. It's actually usually found, it's associated with respiratory disease in pigs, okay? It, however, has developed the ability to move to humans, where it can cause an acute febrile encephalitis in humans. So that's an unfortunate thing. The very first outbreak of Nipah was in 1999, and it was obviously a zoonosis. That's what Nipah is. This is a zoonosis. But since we now know that it has developed this ability, and it was first isolated, I think in Japan, it might have been China, but it'll, now that we know about it, we have to keep that in mind, in particular when you got patients coming from all over the world. The parvoviruses. These are small icosahedral non-enveloped viruses, single-stranded DNA, which it could be spherical. The DNA might curl up in some of these virus particles, but since I don't think you're doing any electron microscopy in your lab, that probably won't come into play. And the key thing about this particular virus family, it is has pretty wide distribution. Most warm-blooded animals can become infected by the parvoviruses. The replication in these viruses occurs in erythroid progenitor cells, and so it will have particular effect on the clinical findings that you have with this. There is a single human pathogen in this group, and that's parvovirus B19. It's generally, again, it replicates in those erythroid progenitor cells, meaning your bone marrow cells, but remember, another erythroid progenitor are fetal liver cells, so it can grow there as well. And the disease associated with B19, the disease is called Fifth's disease because it's the fifth type of childhood rash diseases that can occur with this. And in most cases, you'll see the mild form of the disease, thank goodness, where you see here you get this what's called slap cheek rash. It looks like somebody hit his cheek, right? His cheeks are really red, like they've been slapped, okay? Unfortunately, if a patient has some kind of underlying hemoglobinopathy or in fetal infections with this, because it crossed the placenta, so a mom gets B19, parvo and B19, and it crosses the placenta. In either one of those cases, it can lead to an aplastic crisis, and in the fetal case, that aplastic crisis can lead to hydrops fetalis. So obviously that can be fatal. So this particular virus, while most of it is fairly mild, it is a biphasic illness. In the initial phase, the patient will have a fever, malaise, myalgia, and chills, so they'll feel uncomfortable. in that phase, you actually have the highest levels of viruses, and you'll have a pretty significant, you'll know that you'll feel ill in that phase. But then and you'll also have red blood cell or erythroblast destruction. So these are the red blood cell progenitors in the bone marrow getting destroyed by the virus. It's in the second phase where you end up with the rash. And you'll also have arthralgia or joint pain. And the virus will actually be gone from the bone marrow, but at this point, we can see the antibody response against it. So this is about a week into the infection, where you'll see an IgM, and then about another week, about 14 days, you'll see an IgG. Okay, we're going to diagnose you with this using serology. We can get your paired specimens for serology. We also have PCR. We can do a PCR, but remember, if it's past that first phase, the virus is gone. You might have lower viral load, so it might be harder to detect. We don't have a good cell for parvovirus. Doesn't grow well on our routine cells, so you have to use some other cell types, some uncommon ones for cell culture, which makes it ungainly to do a cell culture for parvo. So you're going to rely on your PCR and your molecular and your serological diagnostic techniques. If you can get it to grow, generally speaking, in this case, we didn't grow it in a cell culture. We actually took a piece of the bone marrow out of the kid, and you can see the CPE already there. Look at the giant pronormoblast here with the arrow pointing to it, and the little arrow is pointing to the intranuclear inclusions that are present. So we're kind of seeing the CPE out of the patient's own cell culture in their bone marrow. Okay, of course, collecting okay, the picornaviruses. The picornaviruses are these are among the simplest of the RNA virus, although their capsid is very highly structured, and it's actually kind of pretty. Okay, the picornaviruses include the enteroviruses and the rhinoviruses, as well as hepatitis A virus. Okay, so it's a pretty broad group of viruses. They're single-stranded RNA, non-enveloped small viruses. Okay, the enteroviruses, remember, this is one of the most common human viral infections. You can get a mild, most of them are mild gastroenteritis, or you can get severe gastroenteritis. But this is the most common cause of clinical gastroenteritis that we see in humans. Enteroviruses are also capable of becoming systemic and causing meningitis, as well as paralytic poliomyelitis, as well as encephalitis. It can spread to the respiratory tract, the heart, the pericardium, any of those. Okay, so we need to be aware of these because they can cause a significant amount. Even though most of them will cause you gastroenteritis, that'll be self-limited, it can be dangerous. Okay, so the enteroviruses, the most common ones, A through D, are shown there, and they're common viruses you see around the world. Again, you don't necessarily develop long-lasting immunity against them. Okay, one of the ones that we can work with as far as immunologically is poliovirus. Poliovirus is an enterovirus. It does cause gastroenteritis. And in some patients, that can become systemic. It can get through the immune response at the Peyer's patches at the GI tract, and it can cause a systemic infection. And then, of course, it's famous for causing poliomyelitis or paralytic poliomyelitis, which can lead to infantile paralysis or for a long-lasting effect. Before the polio vaccine, we do have a vaccine against polio. We have 2 vaccines against polio. Before that, polio caused several outbreaks of paralytic poliomyelitis, around the world in the first half of the 20th century with thousands of people, mostly kids, and they developed that characteristic acute flaccid paralysis, which could, depending on where it infected, where it entered the spinal cord, affect their breathing. And so you saw pictures of kids in iron lungs, and then, of course, we didn't know it necessarily at the time, but the president had it, and the whole thing. Now, that was actually a very large outbreak because it was still a relatively small number of kids. Only 1 to 2% actually developed the paralytic poliomyelitis. Even with systemic infections, some of them would be just very severe respiratory illnesses, but not paralysis. And the iron lungs, if you've seen pictures of them, basically is this giant machine that would create negative pressure around the thoracic cavity, mechanically drawing air into the patient's lungs so that it breathed for them. But they lived basically in this giant iron coffin-looking thing with their head sticking out. We obviously have better technology now. It was in 1955 that Salk came out with his inactivated vaccine, which is the injected version of the vaccine that creates immunity. And then it does create immunity, although not necessarily at the site of the infection, and it's relatively weak. In 1961, Sabin came out with a live vaccine, which then created much more robust immunity at the site of the infection. And so in the 1980s, the WHO began a massive campaign to eradicate polio. And that's not an easy thing because polio does infect it can infect other animals. You can have reservoirs. Even though we're its natural host, it can technically infect other animals. And it's pretty stable in water, which is where you get it from dirty water. By 2006, the number of countries where it was still considered endemic were reduced to 4, and those 4 were Afghanistan, India, Nigeria, and Pakistan. That doesn't mean you don't need your vaccine here in the United States. You do still want your vaccine. Whether we can eradicate it completely from the earth is hard to judge, okay? Let's see. Then we also have the Coxsackie viruses, and those are on this chart over here. You can see here Coxsackie virus. This is a group of viruses. It's an enterovirus. It's human host. It generally does cause gastroenteritis, although it can cause a rash as well that's associated with that. That's characteristic of it. It's still pretty self-limited. It's not usually a major issue. It's just sort of ugly as you go through it. And then you also have echovirus, and these are all characterized based on their CPE and the disease type that they have. These days, instead of calling them Coxsackie or echovirus or anything like that, we separate the enteroviruses into 5 species, A through D. But polio is still left out by itself because of its uniqueness. It's still left out by itself. So you have enterovirus A through D and then poliovirus. Okay, so we've kind of abandoned the old classification system. Then we have, and the transmission of the enteroviruses is both respiratory and fecal oral. Okay, you can do both of those. But the specimen of choice, if you have a doctor who suspects an enterovirus, the specimen of choice is going to be either a stool or a rectal swab. But look at the symptoms. If the patient is experiencing respiratory symptoms, then you can also do a throat swab or washings. And if the patient is experiencing paralysis, then CSF, or any kind of neurological changes, then CSF would be the thing. Okay. It is also possible there is a particular enterovirus called enterovirus 70. It's a unique enterovirus, which causes an acute conjunctivitis. So conjunctival swab is also possible, or tears or something like that. Okay. There is no one cell line that'll support all types of enteroviruses. So for that purpose, the reference lab has to use a variety of cell lines. But by doing that, they can get it to grow faster, and usually you can see the CPE within about 24 hours. It can even destroy the entire monolayer within about 24 hours. At that point, you'll do your confirmation test and get a result pretty quickly if it's positive. But you do have to use more than one cell line. There are molecular tests out there, which, as you probably are aware, molecular tests are definitely more attractive to labs than cell culture. So those are outpacing them. More and more labs are buying them. Also included in the picornavirus are the rhinoviruses, which are the causative agent of the common cold. Okay, the primary infection site for a rhinovirus is in the epithelial layer of the inside of your nose. More than 50% of colds, of viral colds, are caused by rhinoviruses, and there are a number of serotypes of rhinovirus, which is why you don't really have any kind of, you have immunity against the one you had, but there's plenty more others. There's more than 100 serotypes of rhinoviruses. So having an antigen test, that's not going to work since there's 100 different types. You have an infection with a previous one, you don't get immunity to all the serotypes. Okay, we already know that. If it's vital, that most of the time you don't need to look for rhinovirus, but let's say it's vital, you have to find out if this patient has a cold for some reason. Obviously, you'd want nasal secretions because that's the site of the infection, and you can grow it up for culture. Usually, you'll get the CPE in 1 to 4 days, so the patient will be better by the time you identify them. Remember, this likes the nose, right? The inside of the nose, which is slightly lower in temperature. So if you reduce the temperature of your cell culture line to 33 to 35 degrees, you'll have a better chance of growing out the rhinovirus at that temperature. Another important member of the picornavirus is hepatitis A virus. Remember that this is an infectious non-chronic hepatitis, okay? It is transmitted through the fecal-oral route through contaminated food or water, and you could have some household contact with an infected person. That is possible, but it's still fecal-oral. So, you know, somebody in your house has hepatitis A, and you guys aren't clean, and you end up with hepatitis A moving through the house. But it's still through contaminated food or water. Okay, and this differs from other picornaviruses in that where the other picornaviruses have tropisms, with the exception of polio, mostly to mucosal or endothelial or epithelial layers. Hepatitis A obviously has a tropism towards the hepatocytes. So it goes for the liver. It is pretty stable like other hepatitis viruses, and unlike other picornaviruses, and we can easily grow it in cell culture. Again, different from other picornaviruses, but usually diagnosis is done pretty easily with serology. So we can do serology and get you a diagnosis. There's not a normal level of hepatitis A. If you have hepatitis A, you know, your liver is inflamed, you're pretty sick currently. So we have to do serologies in that case because we got to rule out the other causes of hepatitis. The polyoma viruses, these are a unique group of viruses. They're small, non-enveloped, circular, double-stranded DNA viruses. And it's just a small group of viruses that are interesting in that the initial infection isn't what we notice. It's actually the reactivation of the infection. So you might find latent infections of these viruses in a number of people, and they'll be fine clinically. If the disease reactivates, however, the disease can be severe. So the JC and BK viruses, they're just named after the people from whom the virus was initially isolated. Um, Generally, these are early childhood diseases, these two, BK and JC. And they're not anything that you might notice. You know, your kids are always sick. They always have a little something that looks like a cold or something that looks like a mild flu, okay? So you're not going to run to the doctor, and the doctor's not going to identify anything, okay? They have a cold or they have the flu or whatever. However, they set up latent states. And the latent phases that they set up are in the case of the BK virus in the kidney, and in the case of the JC virus in B lymphocytes. And it's during reactivations, which can occur anytime after that, in particular likely during a period of immune suppression. And in those reactivations, they can cause very significant disease. JC virus, if reactivated, will cause a disease in the central nervous system called progressive multifocal leukoencephalopathy, which is a very serious situation for the patient. In this case here, we can see this is a brain biopsy. Obviously, not going to do that just to find the virus, and it shows an oligodendron. Let me see my pen here. It shows an oligodendron. Frankly, I look at this, I have no idea what it shows, but they tell me that this is an oligodendrite with viral inclusion bodies, which give it kind of a smudged appearance at the nuclear site. And you can see these nucleus, they kind of look out of focus in a sense. You can also see enlarged, bizarre eosinophilic astrocytes in the brains of patients with this. Basically, in order to confirm JC, they have to do immunohistochemical analysis. So they do special stains on those biopsies in order to verify JC infection. It doesn't bode well for the patient. BK virus, a little bit different. It causes hemorrhagic cystitis upon reactivation. And so this is a urine for the BK virus. We see the urine that was sent to cytology. And when you look at those cells in the urine, you can see that the decoy cells, with the arrow next to it, you have an enlarged nucleus with a large single basophilic intranuclear inclusion, that's the arrow pointing to that too. Okay, so that's what you're looking for with the BK virus. But cytology is going to do this work, not us. There are newer viruses characterized in this family, a little less information about them. You've got the KI virus, the MC virus, and the W virus. KI and WU, really we don't know a lot about their pathogenicity or prevalence, but the MC virus, actually we do know a little bit about it. Upon reactivation, it can cause something called Merkel cell carcinoma, which is associated with a high percentage of tumors and been detected in the respiratory systems of affected patients. So this is a particular type of cancer associated with that virus. You know, us microbiologists, we believe that you'll find a viral or bacterial cause to every disease out there, because that's what we do. And then another virus that's historically significant, let's not call it clinically significant, but the SV40 virus, or simian polyomavirus 40. This is historically significant because in the late 50s and 60s, during the manufacture of the Salk vaccine, the Salk polio vaccine, it became contaminated with the SV40 during its production, and it was sent out and it was used in really hundreds of patients before the contamination was noted. And the historical significance, not yet proven to be a clinical significance, is that SV40 polyomavirus is associated with tumor production in animals. Okay, and so the fear is this is not something that these humans naturally acquired, but it was injected into them. And so with that, the SV40 vaccine is something that we monitor those patients that were given that vaccine for tumor production because of that potential that's there. And so that's something historically, if a patient had that particular vaccine, we need to know about it so that we can monitor them, because obviously if it can produce tumors, there's no reason why it wouldn't produce it in humans. They didn't obtain the virus naturally, but it's still in them. Okay. Now, diagnosis of either the JC or of any of these viruses would be done with PCR. We don't have serological methods for this. And you would take, for the JC virus, you would need a CSF sample or brain biopsy. For the BK virus, you can use PCR or you can use a cytology of the urine, either one, as I showed you here. The pox virus, yet another very famous virus. We still have to study it. It is one of the most feared, this family contains one of the most feared viruses, smallpox. The virus itself is very large. It is the largest and most complex structurally viruses that infect humans. It does have a double-stranded DNA genome. And you can see the shape of the virus. It's very large. It's either oval or brick-shaped. They can be between 200 and 400 nanometers long. Okay, so that's quite large for a virus particle. You can actually see the pox virus under the light microscope. It's that large. So, that's similar in size to some of the bacteria that we use. Historically, we've known a lot about this virus, and as well as a vaccine for it for a long time. In 1798, it was Edward Jenner, who I guess was flirting with the milkmaids out there at the barn, and he noticed that the milkmaids who had previously gotten a pox disease called cowpox, they never received they never got the smallpox. They never, even when it would go through communities, they didn't get it. And so Edward Jenner postulated that patients who got cowpox, which was actually a mild pox disease, wouldn't get smallpox. And he determined, and so he started a program, he started a thought process that was present then. One of the unique things about smallpox is that it only infects humans. So only humans are infected. It's one of the reasons why we were able to eradicate it as well. Only humans are infected by it, so there's no animal reservoir. But there are two distinct subtypes of smallpox. Variola major, which by its name you can tell causes the more severe disease and has a fatality rate of 30%. And variola minor, which causes less severe disease with a fatality rate of 0.1 to 2%. Okay, so very low fatality rates for variola minor. Now, people have been vaccinating in a fairly crude way against smallpox for a very long time because of these two different subtypes. Variola minor causes very mild disease, but immune response against it creates a protection from variola major. And so they have historical references way back in, the 1700s of Turkey and Middle East and all that stuff, where mothers who wanted to protect their daughters from this disfiguring disease would find somebody who had a mild case, variola minor, of smallpox, and they would take a pox. They would actually take a scab off of that patient and scratch it into the buttocks of their daughters. I don't know why just their daughters, but of their daughters, which would cause a local, small, mild infection of the daughter. So she'd have this scab on her tuchus, but it wouldn't be anywhere else, and so it would maintain her beauty, and they'd be able to marry her off better. And it was actually during the travels of some, English nobility, that this process was recognized, that what they were doing to protect their daughters, and they brought it back to the areas where it was a problem, and started doing it to protect their daughters. Okay, but in the early 19th century, the WHO began an eradication campaign where vaccinations were started to protect the human population, and this was a highly successful eradication campaign, so that the WHO declared naturally occurring smallpox, or smallpox in the wild, eradicated as of 1980. The reason this was successful is because, one, this only affects humans, so there's no animal reservoir, there's no environmental reservoir. You can see everybody who's infected. There's no latent or subclinical infections. You can see it. And also, it's very easy to inoculate people. You can see this poor little girl's not having a good day, but you can see they use this dosing gun, which would actually create a little cut in the kid and sort of scrape the virus into the skin, just lightly. This is a long time ago. They've stopped giving out the vaccine in the United States in the early 70s. So if you know somebody who's as old as me, you'll be able to find their smallpox scar on their arm, because that's where we did it in the United States. That's where the infection was given. So in my family, who kind of our birth dates overlap that, the older of us were able to get it because my mom was a fighter, but the younger of us, it wasn't even available anymore. They couldn't get it. Only the Army has it, and researchers have it today in the United States. But besides smallpox, there are 10 other pox viruses that can infect humans. Most of them are zoonotic. The only exception would be smallpox, which is human to human, and then another one, which is molluscum contagiosum virus, and we'll get to that one. The only ones that can actually sustain human-to-human transmission in the pox virus are smallpox and monkeypox. And those are the only ones. Normally they're acquired through some kind of abrasion in the skin, but monkeypox, which is occasionally a problem in little outbreaks, that can be acquired either through the mouth or the throat. Okay, and what happens then, once it gains access, it'll replicate in the epidermal cells, changing the cellular structure, creating this pox that's on the skin. And you can see in this picture here the changes that occur over the days of the kid's infection. In this case of smallpox, it leaves scars, and you can see that here. These are going to be lifelong scars. Okay, there's not going to be any relief from this. It's also painful, a process, much different than like chickenpox or anything like that. Now, the two possible courses associated with the two different strains is either a localized infection that has little spread, that's variola minor, or a fulminant systemic infection with spread throughout the body. And that type of infection is associated with variola major. It's also associated with monkeypox. Monkeypox generally causes a systemic infection. If you had to try and distinguish monkeypox from smallpox, clinically, the only difference is the fatality rate. Monkeypox is still found in tropical rainforests in Africa, and even though you would think it was only monkeys, its actual host species is a rodent species. Its host reservoir is a rodent species. And actually, we did see outbreaks of this in the United States. In 2003, interestingly enough, rats are a very popular pet in the United States, and there was an import of rats from the Congo Basin as pets which resulted in an outbreak of monkeypox in the United States, where each of the cases were able to be traced back to the pet shops that imported these rats from the Congo Basin. And so the people developed this rash or pox disease, which I'm sure looked very scary, but at least it didn't have the same fatality rate. Molluscum contagiosum virus. This causes the only host for this is humans, and it does cause a pox infection. However, it causes either a single or just a very small cluster of lesions, not nearly as large as smallpox or monkeypox, and it usually is self-limiting. The only time it will be severe is in the immunocompromised, where then it does have the opportunity to spread. Okay. And then just one more member of this virus that can cause problems. It's a zoonosis, but it can cause problems, and it's called ORF, which is just a weird name, but there you go. It is another member of the pox virus, and it's transmitted from sheep to humans with direct contact to infected sheep. So the sheep has some kind of lesion or pox on its body. You're the sheep farmer, you come in contact. And basically, this will cause fairly local infection. Usually you'll have either a single or even multiple nodules. It'll be on the hands where you were in contact with the sheep, but it can be quite painful. The biggest problem with ORF is that although it is self-limiting, the pox do contain replicating virus, and one of the things that they have seen is auto-inoculation of the eyes, which can cause pox on the eyes, which of course can lead to blindness. That's no good, and other serious complications. But that's auto-inoculation. So you have the pox on your hand and you rub your eyes and basically force the virus into your eyes. So don't rub your eyes with your pox-filled hands. Okay? Little tip for you. The reoviruses. The reoviruses are small icosahedral non-enveloped viruses. They contain segmented, you can see here in the cartoon here, segmented double-stranded RNA as their genome. And they have 3 concentric protein shells, which you can kind of see here in this, that you have an inner capsid, you have an outer capsid, and then you have this serves as the brace for the outer shell. There are human pathogens within this group, and they include rotavirus and cultivirus. These viruses were first, or reoviruses, were first isolated from respiratory and enteric specimens. And so that's kind of where they get their name, respiratory enteric orphan viruses. So they didn't really have any other way to group them. That's how they grouped them. REO, respiratory enteric orphan viruses. And that's because initially when they isolated them, they didn't have a disease to associate them with. But now we know better, and we know that most mammalian species can be infected by these, and we can find these viruses easily in any water that's been contaminated with feces. Okay, rotavirus causes gastroenteritis. It's particularly virulent in young kids and underweight babies and the elderly. If you got it, you'd have a really bad case of diarrhea, gastroenteritis, and you'd be pretty uncomfortable. But it can cause you significant loss of water in infants, and so it's in the kids that we really watch for rotavirus. It does cause a very watery diarrhea, and it causes very, very painful cramps. So it can start as vomiting, diarrhea, and then loss of the lining of the gastrointestinal tract. So everything is shed. It's just dumped into the stool. It's very uncomfortable for the kid. And then we have cultivirus, which is actually the cause of Colorado tick fever. Okay. In diagnosing these, the rotavirus at this point actually is pretty easy to detect. We have little kits in the laboratory little, cartridges that we put some diluted stool into, and we can identify the presence of rotavirus. In an outbreak of rotavirus, we need to do some epidemiology, and that's done through the distinct groups of proteins in the shells. There are 7 distinct groups, A through G. The human disease is caused by the shell groups A, B, and C. But there's an awful lot of cases of this, 111 million cases annually, with more than 2 million hospitalizations annually, and 352,000 to 592,000 deaths annually with this virus. In this particular group of patients, 6 months to 3 years old, it's a very significant cause and danger to their lives. And the reason is the loss of water is so evident. There's so much loss of water that they can end up with a heart attack. We also have automated mechanisms to test this: ELISA, latex agglutination. We can do PCR, a whole bunch of things, cell culture, whatever you want. But the little cartridge kits are probably the easiest way to go. The Colorado tick fever, it's a fever, chills, headache. There's interestingly a photophobia that goes along with it, and sensitivity to light, myalgia, arthralgia, and lethargy. But in children, it can be particularly dangerous because they can actually, cultivirus can become systemic, and it can cause a hemorrhagic disease. One of the things that's characteristic of cultivirus is a leukopenia that is both lymphocytes and neutrophils are affected by that leukopenia. It is, and those are very common findings with Colorado tick fever. And that can lead then to either encephalitis or meningitis. So it's another virus that we have to be on the watch for in kids, mostly. Reoviruses, kids. The retroviruses, I'm sure you've heard of these before. These are enveloped single-stranded RNA viruses with a reverse transcriptase protein that's included in the virion that will direct the replication of that virus through a DNA intermediary. Okay. These viruses primarily infect invertebrates, primarily. Okay. The two groups in there that infect humans, and of course are very important pathogens for us, are human immunodeficiency virus, or HIV, types 1 and 2, okay, and human T lymphotrophic viruses, also types 1 and 2. Both of these were isolated in response to the search for the cause of AIDS, or acquired immune deficiency syndrome. And interestingly, HTLV was the first one isolated, and it was thought that that was the cause. It did have a very high rate of infection within that group, but it turned out not to be the cause, and that's because HIV was then later identified in 1983 and found to be responsible for the AIDS pandemic of the 70s and 80s. And that was HIV-1 that was obviously first found. Later in 1986, a few years later, HIV-2 was isolated, and while it was found to be present, it is found to be less pathogenic than HIV-1. Still not something you want. Both of them have an affinity for the CD4 positive surface marker of T lymphocytes. So as those cells become infected, the populations decrease, which leads to an overall diminishing of immunity. And so the patient is overwhelmed by infections and diseases that normally they wouldn't have a problem with. Normally their immune system would have no problem with them. But without those CD4 positive cells, your immune system is really hampered. It's really hindered in its capabilities. The tests that we do for HIV, we do antibody tests, and we never rely on just one. Antibody tests always have to be repeatedly reactive. It's the same specimen, but you have to run it twice. and then it's confirmed with Western blot. And that's because the antibody test is not specific enough to just rely on that. So then you have to move to the Western blot. HTLV1 is, or human T lymphotropic virus 1, that's endemic to the Caribbean, Africa, South and Central America, Malaysia, and Japan. But it's not very pathogenic. Only less than 4% of infected patients will develop any kind of symptoms. Unfortunately, this particular virus is associated with T-cell leukemia and lymphoma. So you might develop, what I'm trying to say there is that you might develop no symptoms on your initial infection with HTLV1, but a latent infection could be set up in the T cells, which then can, at a later date, lead to a T-cell leukemia or a lymphoma. HTLV2 has also been identified, but no known disease associations have been assigned to HTLV2. The interesting thing about HTLV1 is that the period of time between infection development and the actual leukemia development is very long, about 40 years on average, between infection and the development of the lymphoma. So that's incredibly long, okay? The rhabdovirus. The member of this that is our problem, and is still a serious problem, is rabies, okay? This is a neurotropic virus, so it moves directly towards the nervous system, in particular the central nervous system, and it affects all mammals, absolutely all mammals with almost no exceptions. And with very few exceptions, it will be a terminal disease. So it is almost always fatal. Now we do have treatments for humans, but the success of those treatments depend on how rapidly treatment is begun. It is transmitted through the saliva of the infected animal. If you test the saliva of an infected animal, it's absolutely jam-packed with rabies viruses. And because of the clinical symptoms of the disease, usually that saliva transmission is through a bite, although you have to be very careful. These animals are spitting and throwing saliva everywhere, and that is, it's in the saliva, so it only has to get on you, and it's a risk, okay? But if you're talking about a bite, which is the most common means of infection, from that bite site, the virus will invade the peripheral nerve and move up the peripheral nerve to gain access to the central nervous system, moving from neuron to neuron. There have only been 6 cases of survival of rabies viruses documented worldwide. That's pretty amazing, okay? In 2004, what's called the Milwaukee Protocol for treatment of rabies was developed and is considered the standard at this point. And it calls that a patient remain in a prolonged state of general anesthesia with antiviral drugs and supportive life-sustaining care until that patient either achieves some kind of natural immunity that is capable of clearing the infection or they die. Okay, so it really is speed. And the closer that bite is to your brain, the faster that disease is going to move. A bite on the foot takes longer than a bite on the hand. That's the reality. The virion itself is a helical nucleocapsid with a lipid bilayer envelope. It kind of looks like a cell, okay? But it does have these spike-like projections that emerge from the lipid bilayer against which we can direct an immune response. The fact that it moves from neuron to neuron across the junction, it assists in it from hiding from the immune system, okay? The overall shape then, from the way the virus is structured, it gives it an overall bullet or conical shape, which just adds to its mystery. The genome is single-stranded RNA, and the virus itself can produce 2 clinical pictures. So you have what's called, and these are kind of ancient words, but you have either furious rabies or dumb rabies. And the clinical picture usually is based on how quickly the virus gains access to the brain. So, and here, if I can try and explain this, as the virus moves from neuron to neuron, basically it leaves every neuron on. It's kind of like turning on every light in the house. So every neuron is turned on all the way. So the amount of pain that this animal, in the case of this dog here, that this animal is feeling is incredible, which leads to the anger or the furiousness of the dog. They're biting and furious because they see you as a threat, as the potential cause of their anger. The frothing at the mouth is there because the swallowing process, which normally brings the tissues of the throat together, that's normal swallowing, is so painful that the animal doesn't want to do it. And so the saliva spills out and they froth at the mouth. This leads to a general state of dehydration, which only emphasizes the pain, and also leads the animal to seek out water because of the dehydration, which is why you see animals at times of the day when you wouldn't normally see them, right? So when you see a nocturnal animal in the middle of the day, that's a warning sign. You do not approach them. That's the most common one that we think of with rabies is furious rabies. However, dumb rabies does exist, and it's generally associated with bites or infection sites closer to the brain. So in this case, what we see is that the brain is affected so quickly. So this poor dog's brain has been affected so quickly that the motor, they're overwhelmed and there's almost no motor output. You still have a lot of pain and you can see the frothing at the mouth here, but the dog by dumb, we mean it's not doing anything, it's just sitting there, okay, to the point that it can actually become floppy, okay. And these can be experienced by humans as well. Diagnosis of rabies is done according to New York's Department of Health standards by exam of the brain tissue with a direct immunofluorescent assay. If you have an animal that is associated with a bite and has either died and dies within a year of that bite, so there's some kind of bite, either they got bit from a wild animal or they bit somebody and the bite is reported. If that animal, and mostly it's dogs that we come in contact with, but if that animal dies within a year, its body must be sent, or its brain must be sent to the Department of Health, and this test must be done to verify that there's no rabies in the dog or whatever the animal is. If you have a dog who's bit by a wild animal and your dog hasn't had his rabies vaccine, basically the dog goes in quarantine for a year. The rabies vaccine does work very well, although it doesn't produce a long-lasting immunity, so it does have to be updated. It is not recommended for general use by people, and that's because it does not provide long-lasting immunity. So instead, it's only given to those patients who are at high risk. So animal workers who would come in contact with these animals, whether it's a vet or some kind of animal control officer or something like that, they might come in contact with these animals and they get the vaccine. But the rest of us, it's not considered, it's not recommended unless you're high risk. It is, however, recommended for our animals because they go out in the woods and they come in contact with other animals. And so for them, it is considered recommended. It's actually required, okay, by the Department of Health. And then finally, after a very long lecture, the toga virus. Toga virus is a icosahedral enveloped linear single-stranded positive sense RNA, and it actually has pretty varied tropism. It can infect a number of different cell types. And it includes two viruses which you're aware of, well, one which you're probably very well aware of, the rubella virus, is a togavirus, and it also includes the alpha viruses, which is a large group of mosquito-borne arboviruses. Rubella is the most significant in this group, and it's only found in humans. Rubella is. It's transmitted via nasopharyngeal secretions, or it's transmitted vertically from mother to fetus during pregnancy. Rubella is also known as German measles. Okay, usually if you get it, it's fairly benign. You get a fever and a rash. But before the vaccine, it could be epidemic, like it could just go through schools and things like that. So you ended up with German measles. The people who are at highest risk for rubella infection are pregnant women. Not so much for themselves, except that it causes multiple congenital anomalies of their children. In particular, if they're infected during the first trimester. First of all, it would be low birth weight, mental retardation, and deafness, congenital heart disease, and neurological defects all are potential results of first trimester infection of a fetus. Later in the pregnancy, if they are infected, you can end up with splenomegaly or osteomyelitis, as well as some other birth defects that could potentially occur. Rubella syndrome itself for children born who were exposed to rubella during pregnancy. Microcephaly is very common, which will give you a lot of the neurological and developmental delay pictures. It's not even really just delay, it's just inability. They're not going to catch up. They're never going to catch up. Patent ductus arteriosus, which is a vascular abnormality in the heart, and cataracts. These are characteristic of rubella syndrome. Now, the alpha viruses are, again, those are arboviruses. It's a group of viruses, and they're actually important in the equine world. And we do have some vaccines for some of them, but it includes those that cause Western, Eastern, and Venezuelan equine encephalitis. They're different viruses that cause encephalitis, which if you work with horses can be devastating to your her, I don't know, her family, hers, I don't know what it's called, to your barn full of horses. Okay, my sister will be very disappointed that I don't know what that is. And there's not as the information about togaviruses as far as the disease process. What we do postulate at this point is that the likely attachment site are these spikes that are on the outside of the virus, which is a pretty good guess because that's pretty much how it works with the rest of the family of the viruses. Okay, and so again, for the most part, rubella, if you're not pregnant, it's usually not a major problem, except that you can transmit it to any pregnant woman. It's very easily transmitted. And this was a very long lecture, but we are now finished.